All right. Thank you all for taking the time to join us this afternoon. My name is Haley Troy, and I'm a coordinator at the Center for mHealth and Social Media at the University of Connecticut. And I am truly honored today to introduce our speaker, Dr. Megan O'Grady. Dr. O'Grady is an assistant professor of public health sciences at the University of Connecticut School of Medicine. She is an applied social psychologist and health services researcher. Her research and evaluation program aims to improve the system of care for and prevention of substance use disorders and focuses on three main areas. One, implementation of integrated care practices. Two, development and implementation of technology tools for health and addiction care settings. And three, quality improvement and systems level interventions. Dr. O'Grady is the principal investigator on an NIH funded study examining the implementation of a text messaging program for unhealthy alcohol use in emergency departments. She's also co-investigator on 4 NIH funded studies on substance use services, and she's also the lead evaluator on several SAMHSA and state-funded projects in partnership with New York State and the state of Connecticut. In addition, she directs the Center for Prevention Evaluation and Statistics at UConn Health. Today, Dr. O'Grady will provide an overview of how implementation science methods and theories can increase the reach of mHealth interventions in clinical practice settings. She'll provide illustrative examples from a study examining the implementation of a text messaging program for unhealthy alcohol use in emergency departments. Thank you again for tuning in. We ask that you please save all questions for the Q&A at the end, and I will now turn things over to Dr. O'Grady.
Thank you so much, Haley. I'm really happy to be here and happy to talk about implementation science and how that fits in with mHealth. Just a very quick overview of what I'm going to be talking about today. So I'll give a very brief overview of implementation science and what that is for folks who may not know, and what the role of implementation science is in the development and implementation of mHealth products or interventions. And then I'll go over two examples about designing mHealth tools and examining barriers of facilitators to implementation, as well as developing implementation strategies. So my area of content focus is substance use, so that's where the examples come from, but this really is applicable to any area of healthcare, so certainly not limited to behavioral health or substance use alone. So why implementation science to start with? So on average, we know that it takes about 17 years for evidence-based practices to be incorporated into routine general practice in healthcare. This can vary quite a bit depending on what the evidence-based practice is. Sometimes this is longer, sometimes this is shorter, but this is clearly too long to wait for things that we know work to get into practice. And even when things are implemented, we know that only about half of evidence-based practices ever reach widespread clinical usage. So implementation science is really trying to address this issue of getting things into practice more quickly and more sustainably so that people are benefiting from evidence-based practices and are not waiting 17 years to benefit from things that we know work well. So, we know that this can be an issue because often as researchers, we develop and evaluate evidence-based interventions or programs, practices, guidelines in settings that don't really reflect the real world. Real world settings are much more dynamic and complex than a controlled environment where many studies take place. And so ultimately, we really don't see things reach the populations that they should. So, and we know that this costs us money and, long-term, there are long-term impacts on patient outcomes. And so a lot of money is spent developing evidence-based practices, both from funding agencies as well as academic institutions. And so to have many of these things never actually make it into clinical practice or be available to people who they could benefit from is a real drain on the system and really can hamper the advancement of clinical quality of care. So implementation science, which is really, relatively speaking, a fairly new area of science, just in the past few decades, is the scientific study of methods and strategies to facilitate the uptake of evidence-based practice and research into regular use by practitioners and policymakers, with the ultimate hope that this we can get things faster into practice and improve patient outcomes and ultimately population health. So we really want to close the gap between, you'll hear people talk about this in implementation science, what we call the no-do gap. So can we close the gap between what we know works and what we actually do in practice? And so we're really interested in this field in developing and testing effective strategies for implementing evidence-based practices within clinical and community settings. I'll be talking a lot about clinical settings today, but I think we can be thinking broadly about a setting that a clinical practice or an evidence-based practice certainly could be implemented, from community-based settings to schools, et cetera. And so we also really want to understand the processes and barriers and facilitators that influence implementation or failure, success or failure across really diverse real-world settings. And there's a lot of sort of development of the theories, models, and frameworks, and really measures and methods in the field. Because it's fairly new, this is an area that's been heavy focus in the last few years. So more recently is really solidifying the methods that we're using in the field. So to sort of visualize this a little bit, just kind of to focus on where the implementation science focus is, if we think about a traditional randomized trial where we might be testing the efficacy or effectiveness of an evidence-based practice, if we look to the left side of this visualization, you can see the what, which is an evidence-based practice. And if we look to the other end of this continuum, we can see health outcomes. So that's typically where clinical research is focused, is, how do we develop an evidence-based practice that can improve, patients' functioning, patient symptoms, and satisfaction in care. And so that's, where most of our research funding and research effort has been historically. Sometimes we also focus on services outcomes, and as a health services researcher, these are also important. But implementation science is really looking at sort of what happens at the in-between. So how do we take an evidence-based practice, develop an implementation strategy to actually get it into play? And, what are our outcomes in implementation science? So they're very different than the health outcomes that we might traditionally be focusing on in a randomized trial. We're really focusing in implementation science on how acceptable an evidence-based practice is in a real-world clinical setting, how well settings are adopting this practice, how well it has reached the people that it is intended to reach, how sustainable practice is, how much it costs. So really different set of outcomes that we're focused on in implementation science work. There are a lot of implementation strategies that folks can choose from, and there are sort of whole compendiums of recommended strategies, and they should really be linked to what the barriers and facilitators are. And so I'll talk a little bit more about how we should think about developing implementation strategies, and that we shouldn't be rushing to just sort of select things that we think will work without having some theoretical or just some formative work done. And then this is really just to illustrate where implementation science fits in the broader continuum of clinical research. And so this is, sort of starts with what the practice of interest is. So if we think about moving from efficacy research to effectiveness research and then to implementation research, that's sort of what this illustrates. So if we have something that an evidence-based practice that we're interested in, has it been tested in efficacy studies? And if not, we should really be thinking about doing that, but designing for implementation from the beginning. So where do we hope that this evidence-based practice will eventually end up? If we do have some efficacy research, we can then move on to effectiveness studies. So moving a little bit more into the real world, having less controls and less sort of strict patient, patient inclusion in studies. And so, we can then think about, okay, is there effectiveness research done? If the answer is no, we might want to think about doing that. If the answer is yes, then we might think about moving to implementation studies. There are different studies that could be done in implementation science, and you can see along the bottom right-hand side of this figure that we might be doing mixed method studies to understand the context of implementation, or we might be designing and testing implementation strategies. So again, we're less interested in whether the evidence-based practice works once we get to this place in the research continuum, and much more focused on how do we actually design a strategy to get it into practice. You can also see sort of just above that bottom line, hybrid effectiveness implementation trials. We can move things along a little faster by thinking about combining implementation and effectiveness trials, and these are used more and more frequently to both test whether something is effective as well as how we can implement it. So where does that leave us in terms of how mHealth fits into implementation science? I put two quotes from recent, fairly recent papers on here that kind of summarize where we're at and where we need to head. And so the first one really illustrates, and I'll just read it, is there are thousands of studies in the literature reporting feasibility, effectiveness of digital health interventions. However, we don't have the answers to how we could make effective technologies practicable in clinical settings. So, this person is suggesting that this is where we really need to head to really move into the future of healthcare. And then the bottom quote, it has a similar feel to it, but focuses more on digital mental health because it was from a review of digital mental health, and suggests that we have an enormous research to practice gap with strong and growing evidence from efficacy trials for more than 15 years about the products and practices that we know work, yet virtually no successful and sustainable implementation. So there's a real opportunity to be thinking about how we can use implementation science in the mHealth field. So what are the kinds of questions that we might want to be asking if we are thinking about implementation studies in mHealth? I've put a number of things here, but there are certainly others. So we might be asking, how do we fit mHealth products into an existing workflow where we know providers may not have the time and training to actually utilize them effectively? So how do we get around those barriers? Who could actually help troubleshoot problems experienced by providers and patients if we're utilizing some sort of mHealth tool or product? Who will help patients get up and running? So how will a patient even know that it's available to them? How will they know how to use it? How will providers fit the use of these into their already packed workflows? How do we pay for these technologies and try to make them sustainable from a financial perspective? And of course, we want to be very concerned about both ethical and health disparities that may come about by whether people can access these technologies. So we need to be very closely monitoring who these are accessible to make sure that we're not increasing health disparities and decreasing equitable access to these. The other thing that I think is very important and maybe makes this a little more complicated in mHealth is that when you say mHealth, that could mean many, many different things. And so this illustration is from a paper published a couple years ago, and really illustrates the sort of continuum of behavioral health technologies in this case. But from the left-hand side, that we can see that we may use technology just to have a human deliver an intervention. So it may be something done over the phone, over messaging, or something like that. And if we move along this continuum all the way to the right-hand side, we may think about an mHealth technology that actually has no provider involved. So it may be a completely patient-facing intervention or tool that the provider really doesn't have a strong role in. And then, there may be things in between where an intervention is delivered via mHealth by the provider with support, or vice versa. So there could be, very different use cases of mHealth and how they might fit into the clinical setting. And it could be, you could think about sort of the end continuum where there's really just a consumer facing use for it, and that might be easier to implement, but the patient still has to know that it's available to them. They have to know how to use it, and they have to see the value in how it's actually going to improve their health. And so even if something is fully automated and the patient can engage with it on their own without really the need to do a lot of heavy integration into a clinical workflow, you still need to think about how that patient gets access to that and who's getting access to it and how they're using it. In the digital mental health field, there has been some good work done to really think about what the barriers and facilitators are to implementing digital mental health interventions into healthcare settings. And so, this is a really nice list that highlights some of the things that have been found in the literature in this area. So, some common barriers might be at the organizational level. So there's just not really the resources or infrastructure to make mHealth technologies available to patients. Maybe there's limited staff resources to actually implement this and limited technical support. Certainly there needs to be buy-in from providers or practitioners, and people have to feel like they're able to use these. So sometimes there's low digital literacy, sometimes mHealth interventions may be too complex for folks. And so lots of things to think about in terms of how to overcome barriers. In terms of facilitators, having strong organizational support, having the availability of developers who can really make these tools accessible to healthcare settings, and really having buy-in from folks and making these convenient tools to use can really help move these along into clinical practice. So I want to move to the examples a little bit here, but just in terms of what I'm going to be talking about for the rest of the talk today, is what is the role for implementation science in mHealth? So I think I want to talk a little bit about how we should be starting from product development. So we shouldn't be developing things without thinking about where they may actually end up and where we want them to end up in clinical practice. And then I'll talk about some examples in each of these areas. So how do we understand the implementation context? How do we design and implement, design and test implementation strategies? So there's a really nice model that was developed a couple years ago, and I wanted to just spend a minute talking about it because I think it's one of those models that actually stresses how we should be thinking about implementation from creation of an mHealth product or intervention. And so this is called the Accelerated Creation to Sustainment model. And really walks through 3 different phases of developing and testing mHealth interventions. And so you can see from the product creation phase, this model suggests that we should be doing very heavy qualitative work during this phase, maybe doing interviews, focus groups, design workshops, cognitive testing, to really understand how the technology should be developed. But the difference here is, even if we're doing that as mHealth developers, at this phase, we should also be developing an implementation blueprint. So not only focusing on, development of the technology itself, but thinking about how we develop the protocols for staff that might be using this, as well as, how this could actually be implemented and what settings we're focusing on. So that's sort of the big difference here from maybe other, sort of technology development models is, using heavy user-centered design principles and bringing the end users, into the process of development, but also thinking about drafting an implementation blueprint. Once we move along the continuum here in this particular model, so we might think about testing our mHealth product, and this model again suggests that once we move to testing our products, we should also be thinking about testing our implementation blueprint. So, could this actually be implemented in the way that we thought? And should we be redesigning and iterating as we get into that phase? And then the final phase here is sustainment. So how do we keep this in practice as we pull away research supports or other supports. So, I just wanted to talk about this because I think it's a good example of, how we can be thinking about using implementation science from the beginning of creating an mHealth product. So my first example is from a study of electronic measurement-based care in outpatient substance use disorder treatment, and really focuses on the first two bullet points here, which are product development and how do we understand implementation context. So just to give a very brief overview of measurement-based care, just to provide context for what this mHealth tool is. Measurement-based care is defined as routinely administering standardized measures to patients and then using that data often in conversation with the patient to inform clinical decision making. So you may be familiar with a tool or a measure like the PHQ-9 for depression. It's used often in clinical practice and provides a database way to see if people are responding to treatment and a way to make sort of information to make adjustments if needed. Measurement-based care demonstrates positive effects on treatment outcomes, but substance use specialty care has been very slow to uptake this concept. There have been a number of potential barriers to implementation identified in behavioral health settings to doing measurement-based care. These can be from the patient side. Maybe patients just simply, do not want to fill out continued assessments over time. Maybe providers don't have time or the buy-in to do this practice, or maybe there's just not resources at the organizational level. The few studies, excuse me, that have been done in substance use disorder treatment settings do show promise in terms of the feasibility of doing measurement-based care, as well as provider openness to doing it. But again, there have been very few implementation studies in this area, so there's a lot to learn. In terms of the measurement-based care tool that we've been using in the studies that I've been doing with my colleagues is we developed something we call the Treatment Progress Assessment, the TPA-8, which is a measurement-based care tool that measures over the past 2 weeks substance use disorder treatment symptoms as well as other progress indicators. So it's an 8-item tool. That can give some information to counselors or other treatment staff to indicate how a client might be doing. We subsequently, after validating and developing that tool, just a paper pencil form, we developed an electronic version of this. So on the staff side, there's a staff portal which they can log into and just sort of for account administration. They also have a report system so they can see all the administrations that a client has done in their reports, and I'll show you an example of what those look like. And then email alerts once a client completes the assessment. And then from the patient mHealth side, we designed this to be for clients or patients to complete this on tablets. So if they come into the substance use disorder treatment clinic, they can complete this 8-item measure, just on a tablet that's available to them in the clinic. And then that information feeds to their counselor or other staff to be able to see, what the results were. And then we also have a text messaging based system where if a client opts into that, and if they have a smartphone, they can receive text message based reminders every 2 weeks with a link to complete the treatment progress assessment tool so that it can be just administered regularly and they can do it right on their phone from wherever they are. So this is just a couple screenshots of what the tool looks like, both from the patient client and the staff side. So on the right hand side, you can see just sort of the patient interface on a mobile phone. We have the tool available in English and Spanish, and you can see on the right that it's a very simple screen. There's one question per screen. Clients can click through it very quickly. It takes them just a few minutes or less to complete this. On the left-hand side, you can see some of the reports that feed back into the staff system, so they can sort of see how a patient's scores might compare over time or might, sort of increase or decrease, and any flags that they might want to pay attention to. So just a little bit about how we moved from just having a paper pencil version of this assessment to the creation of the mHealth and electronic version of this, we spent a lot of time doing iterative testing and development before we had the end results of what you see in those screenshots. We had a multidisciplinary team made up of researchers. We had a designer who was very skilled in user interface because we wanted the tool to be very easy to use. We had state agency partners from state agencies that oversee addiction treatment, as well as a broader stakeholder group made up of substance use disorder treatment providers and other related stakeholders. So we went through development of creating initial prototypes, getting a lot of qualitative feedback from clients and staff, and doing sort of redevelopment and making changes as we got feedback. We did cognitive testing by having clients click through with us sitting there and sort of having them talk aloud about what they're seeing on the screen and how they're moving through it. And we also use a user testing website to do additional think aloud usability testing. And then for the staff-facing piece, we did some focus groups and iterative refinement of both how we thought this could be implemented in these treatment settings, as well as just what the reports, what kind of reports would be useful for them. And we spent a lot of time looking at different kinds of reports, how they were presented, because we knew that people needed to be able to look at these and quickly gather information that would be useful to them in their clinical practice. So this tool has been now implemented in a number of substance use disorder treatment clinics as part of a larger study. And we did some initial work to understand early adoption in these clinics. And so we've done 34 interviews with staff in 13 outpatient substance use disorder treatment clinics about 3 months after they implemented the tool, and recorded and transcribed and did qualitative analysis of this. Our guiding framework, implementation science framework for this work, as well as the other study that I'll talk about, is called the IPARIS model. There are many, many implementation science frameworks. I think there's something like over 100 different frameworks now that could be used. So a lot to choose from that can really guide the work that you're doing. So just a little bit more about the method here is that, as I mentioned, this was a qualitative study embedded in a larger trial. It's a stepped wedge trial studying the implementation of quality improvement practices in outpatient addiction treatment clinics in New York State. As part of this larger trial, the electronic TPA-8 system was made available to clinics, and in addition to a number of other quality improvement practices that they were learning and implementing and utilizing as part of this trial. So it's just one piece of the intervention that was being implemented. And so we used a number of implementation strategies, the main one being what we call external practice facilitation, which means that we have an external person who works very closely with the clinic to help them assess the implementation environment, to overcome barriers, and to work closely with them to really improve implementation and to have somebody who's there supporting them. We also had engaged leadership over time, engaged champions, as well as had change teams or implementation teams who were engaging a lot of people at the sites to really champion this and move this through, as well as creating some training materials. Here's just a little bit of information or a visual about how this has been going so far in these clinics. So in total, we've had almost 1,700 administrations of the TPA-8, starting from July 2021 through the last time we pulled data was November of this past year, so November 2022. Each of these lines, vertical lines, represents a clinic. And so the darker the line, the more TPA-8s that were completed. And you can see that there's sort of a staggered start to when these different clinics started using the tool, and that's because this is a stepped wedge trial where different cohorts are starting and rolling into the using the tool over time. So we can see some pretty variable implementation success, where sort of the one right in the middle, Clinic 2-3, we can see, has been pretty consistent and stayed consistent throughout the data that we pulled. But to the right of that, we can see that there are just a few dots for 2-4 and a few dots for 2-5, meaning they started to use the tool, but then quickly dropped off. So they didn't really implement it and use it in any big way. To the left-hand side, 2-1 and 2-2, we can see that they started to use it and then dropped off pretty much when their practice facilitator stepped away as part of the intervention. So we can see, some clear sustainability issues, but very variable uptake and sustainability. In terms of the qualitative outcomes, this is just a very simple visualization of the IPARS framework. That practice facilitator is sort of at the middle of this model, or sort of one of the main implementation focuses of this model. And then this model also suggests that we should be paying close attention to the context in which implementation is happening both in terms of within the organization, within the clinic or setting that we're working in, as well as what's happening in the outer context. So are there policies that are happening that might impact implementation, for example, as well as the innovation itself. So how usable is it? And the recipients who are going to be using the innovation. So these are the different constructs of this particular model. So I'll present just a few quick, I won't present all of the qualitative information we have because it's quite a lot, but in terms of the innovation, we had 3 different themes here. The degree of fit, the relative advantage of using the ETPA8, which means, is this better than what you were doing before to help you in clinical practice, as well as just the usability of the tool. And what we found was that in terms of degree of fit, that many providers were able to build administration initially of the tool into their sessions, as well as case conferencing meetings when they were meeting with a larger clinical team to talk about their clients. So this was a tool that they could bring to a case conference and say, hey, this person isn't doing well. What more could we be doing, for this person or with this person? But what we found is that it was not normative at all for many of these folks to use data during client sessions to review it. They didn't feel like there was enough time, and it was also difficult to think about how to continually reassess clients. So getting somebody to complete one 8-item questionnaire is one hurdle, but then getting them, having them complete it repeatedly over time so that you can actually see a data trajectory was a real challenge in the workflows here. People did see the advantage of using this tool and really thought it provided new opportunities for communication, and felt that it was better than relying on urine toxicology, which often happens in substance use disorder treatment. We often rely on whether or not somebody is using a drug or not, and not necessarily on all the other things that are, that may be going on. And so this provided new opportunities to look at other data and information about somebody. But sometimes there was a skepticism about the data accuracy. So were clients reporting, what was really happening? And again, just not enough time to really use the data in the way that they wanted, although people did find it a very usable tool. And, the other thing that we knew was going to be a barrier going into this is that it was not part of the EHR, the electronic health record. And so, this was a separate system that people had to log into and use to view the reports. And, so that certainly takes extra time and extra effort for folks. So I'm going to skip through this just so I can get to the other example. So I think that provides an example, for one part of implementation science in mHealth, which is, how do we think about really building in implementation from the beginning of creating an mHealth tool, and then how do we study the just the context around implementation and the barriers and facilitators. So how do we, sort of really understand those things so that we can build better implementation strategies? And we think that we can use what we found here to guide refinement of a responsive theory-driven implementation strategy that we can test in another trial. So moving on to the second example here, which is really thinking more about how do we, once we know what the barriers and facilitators are, and understand the context a little bit, how do we then design implementation strategies and test them? So another study that's currently ongoing that I'm working on is looking at text messaging interventions for alcohol use, and in particularly thinking about how to make those available in emergency department settings. We know that these interventions can work well to reduce alcohol use, but they're rarely offered in clinical settings, particularly a setting like an emergency department where patients may really benefit from them. So our main goal was to really understand how do clinical teams make them available, these sort of interventions available to patients in an efficient way. We know that the workflows are already busy and overburdened, and will patients actually enroll in them? So this is a 2-year study where we have 3 aims. The first was really to do some work to understand barriers and facilitators to implementation. And then we worked with a stakeholder group to develop an implementation strategy in our second aim, so that we can test out that implementation strategy as part of our third aim. So that's really sort of where we're headed with this project. So just a little bit of background to complete aim 1. We first examined screening rates for alcohol use in emergency departments across 17 emergency departments in downstate New York. So the first step in really being able to offer a text messaging intervention for alcohol use is identifying folks who may actually benefit from those interventions. And so we examined how often screening was being completed in emergency departments just to get some baseline information within a health system that we were working in as part of this study, and then conducted surveys with chairs of those 17 EDs to understand what their views are in implementing text messaging interventions using a structured brief survey. And then, so we took a look at all of that quantitative data and identified 2 emergency departments that both were screening very frequently and had high scores on the implementation survey that we did. So we selected 2 EDs to do qualitative interviews in who were high, and then 2 that were low, so that we could sort of take a look at, whether there were differences in low implementation potential sites versus high, based on the quantitative data that we had. The qualitative interviews, so we spoke with 21 patients in the emergency department during their visit. They were patients that had screened positive on alcohol screening. We also talked to 18 chairs and other team members in emergency department settings. In terms of the patient interest in these sort of interventions, so patients, about 90%, so most of the patients we spoke to had mobile phones and used them regularly, and most were interested in this kind of intervention. You'll see on the next couple of slides that we have some patient quotes here that illustrate some of these points. But patients were interested for different reasons. So some people were interested in preventing future heavy drinking. Some people were interested in cutting down or quitting altogether. And they wanted to do this for a variety of reasons. The few folks who were not interested said that they mostly used their phone for work, that they preferred phone calls over text messages, and that they felt they just didn't need it. They had a lot of ideas about what content would be useful for them. And many wanted resources that they could use to perhaps reduce their drinking or keep them from drinking. And they really didn't have. We also asked them about who they preferred to actually offer this to them as part of their emergency department visit. So there didn't seem to be any major preferences about who offered it, but they did feel like their doctor should talk to them about it as part of that visit. We did not hear many concerns about privacy or concerns about cost related to text messaging charges. So not a lot of barriers in terms of privacy concerns. And many folks just really saw a number of benefits to enrolling, from keeping themselves out of the emergency department, using this text messaging intervention as a source of support, and that it would really help them become more active and more healthy. In terms of the chair and provider interviews, generally we saw that the people were felt that the emergency department was a good place to identify alcohol-related problems among their patients, but really hard to meaningfully address. And so they were really interested in this text messaging intervention because, it's something that is not a high burden in terms of providers actually having to do a lot. It's an automated program that basically patients would just need to enroll in, and then it sort of runs from there. And so, the biggest challenge would be just to make patients aware. And so they talked a lot about different ways to make patients aware that this was available to them, and to, sort of use multimodal ways to make sure that the patients were aware, as well as sort of not burden any one particular staff member, and really focus on social workers if EDs had them to offer this. So, they did, the folks that we interviewed here did talk a bit about other barriers. So some patients certainly are going to have low motivation to change or may not be interested. And often patients are very overwhelmed at discharge when they're coming out of the emergency department. So really thinking about the right time to offer this, as well as the right tone of staff to be offering this in a non-stigmatizing way, was very important in terms of what people were saying in these interviews. And really just adding another thing to a busy workflow was a huge concern. But people did feel that the setting, so the context in which we were working in, EDs were very, accustomed to change. They change a lot, and are used to sort of trying new innovations, but very low morale and staffing issues because of COVID and just all the respiratory things that are going on and continue. So in terms of the second aim here, I'll just briefly go over this. So how do we move from, having all of that qualitative information to identifying an implementation strategy? We know that it's a complex task to think about what strategies are going to help move something into practice. There are implementation strategy taxonomies that are available. For example, there's something called the ERIC expert list that lists 73 different implementation strategies that are available. So there are these lists that are available to choose from. But we should also be thinking about the theoretical guidance that we can have from using implementation science frameworks. So what makes sense in terms of the context, but also what makes sense from the theory that we're using. Often strategies are just selected in an unsystematic way based on what people think will work. So they should, really be matched to the context, as well as work that has been done to understand what the context is. So there should be some initial work, qualitative work, to understand what the setting is like before we jump to creating strategies. Often strategies are sort of multi-component. So you might package strategies together. And then, there is a suggestion that we can be using rigorous methods to create implementation strategies, such as intervention mapping, which really means that you sort of walk through a very structured process to think about what might need to change in a setting, how that's going to change, and why you think it's going to change. So at the end of the day, we want to have a strategy that we can actually replicate, that will be useful to other settings trying to implement a similar intervention. So this is an overview of the process that we've gone through in this study. So as I mentioned, we've already completed a needs assessment in terms of our qualitative work in AIM 1. And then we took what we learned in that AIM and presented it to a 13-person stakeholder group as part of the health system that we're working with. And they represent people from the administration of the health system, emergency department providers. We have a patient representative with lived experience with alcohol use disorder on our stakeholder group as well. And so we're trying to get feedback before, as we're developing this through the stakeholder group. So we've had a series of stakeholder meetings to both get their feedback on what we found in our qualitative work, and then come up with what the goals and expected outcomes of our strategy are. we've then put in front of the stakeholder group what we think some potential implementation strategies could be from the literature. So we use the ERIC strategy list as well as our theoretical framework to come to a preliminary set of strategies. We've put that in front of the stakeholder group, and then our final step here is to now take what we've learned from that process and create materials and sort of what we actually need to do to test out the strategy. So we'll have a final stakeholder group meeting to do that. So this is just a visual of what the strategies would be based on our framework. And so again, practice facilitation will be an important part of our implementation strategy. And then we have, several other things that we've identified, based on the different components of this model. So some example implementation strategies to address the innovation and getting it into practice are to identify champions and a change team, and to create a training program so that people understand what this is and how to implement it, and just creating one-page training materials for providers so that they know what they're offering to a patient. And using other practices like auditing data and feeding that back to sites so that they can see how many people have been offered the intervention out of those who may have been eligible. So really using and feeding back data to the sites so that they can see how they're doing compared to other sites. And at the end of the day, what we're hoping to measure is how well did this intervention reach the folks that it could benefit, how feasible it is it to offer in the emergency department, and how acceptable is it to staff within these settings to actually do this work. And then finally, we're starting in March our trial to actually test out our new implementation strategy. So we'll be doing a pilot in 4 emergency departments, two control sites where they'll be doing implementation as usual, and then 2 intervention sites where we'll be testing our new strategy. And we'll really be focusing on, do more patients enroll in the sites where we're really working, doing heavy implementation work. So I want to end just by, talking about some things that I think are important to think about in terms of the future of mHealth and implementation science. This is certainly not there's certainly more things that could be on this list, but I think, we should be thinking about how mHealth developers could be partnering with implementation science experts early on in the development of our mHealth products and tools, and how do we best do that? So I think there's some work to do to understand how we can work together, to think about implementation from the creation of a product. And I think we really need to be paying attention to making sure that implementation is equitable, making sure that we're reaching vulnerable populations or other marginalized populations so that they benefit from these tools as well. Are the current strategy taxonomies sufficient for mHealth purposes? So they were not really developed, the strategies list that we have were not really developed with mHealth products in mind. And so, do we need to think about other strategies that we need to add to these lists to test out? And then, I think we need to be thinking about what the different kinds of mHealth are. So the provider-facing versus patient-facing versus everything in between, and whether there are different implementation strategies we need to be using for different types of mHealth tools, and what the sort of workforce needs and financing strategies might be to make all of this work. Want to just acknowledge my collaborators on the projects that I discussed, as well as my funders, which are NIDA and NIAAA. Thank you so much. Here's my contact information, and I'm happy to answer questions.
Great. Thank you so much, Dr. O'Grady, for that wonderful presentation. Everyone feel free to pop questions in the chat. And also, if you'd like to unmute yourself to ask a question directly, please feel free to do so. Josh, do people have the right to unmute? I just want to make sure. Let's see. Yes, people can unmute themselves. Great. So I can get us started with a quick question, Dr. O'Grady. I know you had spoke a bit about the barriers and the facilitators experienced with using this kind of intervention or framework. And I'm wondering if you could speak a little bit more to how we can ensure that the voices of vulnerable and marginalized populations are heard in this process of conducting research in this area.
Yeah, it's a huge concern, and I think we know that not everybody has a smartphone, for example, and we know that even if somebody does have a smartphone, that maybe they don't have an unlimited text messaging program, or maybe they're concerned about the minutes that they may use, and so I do think that first of all, including patients from minoritized or vulnerable groups are an important start to including them on your stakeholder groups and making sure that they're involved as end users from the beginning, so that we're not, missing an important voice in the process. And then I think really tracking once we do start actually testing out our implementation strategies to make sure that we're including data that can help us understand whether we are or are not reaching the vulnerable populations that may exist in our particular area that we're studying. So I think, starting early on and including those folks from the beginning in our design, but also making sure as we're measuring to make sure that we don't have a disparity issue.
This is Dr. Ruano at Farmington. Thanks for the presentation. Very helpful. I had an issue or a question about rural areas. As we know, substance use disorder tends to correlate with rural environments. How do you account for, particularly in New York State, for example, St. Lawrence County? How do you translate these metrics into rural areas?
Yeah, so for the first project that I presented on measurement-based care, we actually are working in clinics both in upstate New York and downstate New York, so not just in the more populated downstate area. And so we do have clinics that are in relatively rural areas or certainly less populated areas in that particular study. And we found that it is quite variable in terms of Wi-Fi access, for example, and the number of patients who are were willing to opt into the text messaging alerts on their phones. And so, I think something that, we will be doing is taking a look at, whether some of our data that we're seeing, on our back end, some of the user data that we're seeing, is different between rural and more urban or suburban areas. So we haven't seen a huge difference yet, just sort of qualitatively in terms of where the clinics are located. Though, we've had different waves of COVID, for example, and staffing issues. Sometimes they're happening downstate when they're not happening upstate and vice versa. And so, in the more rural areas, it's harder, for us sometimes, to find staff, for example, to staff these substance use disorder treatment programs. So yeah, certainly, something to think about, though we haven't particularly addressed it yet in the studies that we're doing.
Well, the another issue, and I'll stop there, is the dynamics. I mean, the rural communities tend to be far more homogeneous than the urban communities in terms of ethnicity, and I have noticed the issue of stigma does then in part separation in the otherwise homogeneous communities. The stigma separates them.
Yeah.
So there are some special dynamics in rural areas that I think we should be aware of.
Yeah, absolutely. Agree.
Hello.
Hi.
This is Ting Zhou from UConn Digital Media Design Department. So I heard you mention you worked with a designer team for this intervention design, mHealth design. So I'm very curious about how do you guys work together design like a user-friendly interface? And also, how did you guys do the user tests based on, focus on design parts?
Mm-hmm. Yeah, so we were lucky enough to have a designer that we've worked with on a number of technology projects for the project that I mentioned. And so, we selected from the beginning somebody that we knew had a strong focus on user experience. So that was our first task, was to really find somebody was going to design by really understanding what the environment was, that we were going to be using this mHealth tool in. So we spent a lot of time in the beginning just talking about what the use cases are, for the tool. We also often, when we start projects, we come up with other products or examples that we like, from the beginning, to say, here's something I like about this. Here's something I like about this, or, certain products we don't like, so that we're all on the same page before, the designs even hit the page, from the beginning. And then, typically the designer will come up with, a bunch of different examples. And then we sort of work to iteratively select, ones initially that we think would be useful to test. And then we typically take it into the field. And so some of our team would go to a clinic or meet with, folks remotely, which had happened a lot during COVID, to really put things in front of, people and do cognitive interviewing, meaning I'm asking you questions as you're going through this product, or I'm having you think aloud and just tell me what you're, sort of what you're experiencing as you're going through this. Or we also used a user testing website that we could actually assign tasks and then see how well somebody was able to complete a task. So were they able to, log in and, complete an assessment and, get through the whole process? And were there any errors along the way, so that we could see if there was an error in a certain task that we needed to redesign the interface for that. So a lot of, different steps along the way, and, trying to stop along the way to make adjustments and then get it back in front of people.
Thank you so much.
Great, thank you. I see that we're running out of time, so I just want to thank everyone for joining us this afternoon. Of course, thank you, Dr. O'Grady, for your thoughtful discussion on the topic. And if you have any remaining questions, please feel free to reach out to Dr. O'Grady via email. I'm going to pop her email in the chat. Yeah, that wraps up for today. But thank you again, and yes, please be in touch if any questions come up.
Yeah, thank you for having me. Have a great day, everybody.